We hear a lot about substance use disorder, anxiety, depression, sleep issues in chronic pain, and this module is going to focus on how we identify and manage some of these comorbidities.
What are the most common comorbidities that you hear from patients with chronic pain? What is what they share with you?
But often it's depression and some sleep disorders, or just they just report difficulty sleeping because that's something we ask specifically about. Fatigue is another large one, just too tired to do any exercise or to move around. So.
And how do you approach that?
So for depression, we don't treat that. We will report that to the primary care physician or as needed. For sleep disturbances, we take the patient through sleep hygiene and things that they need to be doing during as they're approaching bedtime to make sure that they get restful sleep, addressing any of their sleep environment, that it's cool and it's quiet and it's dark, and then go through a routine that they need to be going to bed at the same time and waking up at the same time. And for fatigue, that's a really difficult one, but some of that comes to education. As you exercise, you actually end up with a lot more energy. And they all are willing to admit that when they were more active that they did have more energy. Whether or not they attribute that to having more energy that they were more active or vice versa, we can usually make that connection and then start to get some buy-in that way.
I think that that's great, and that really shows, again, the team, because we preach that, but it's nice to see that as a team we are all working towards the same goal. And Jeff, obviously, well, you probably see all of them too, right? Not just the depression and anxiety. But with what comorbidity do they usually approach you the most?
Well, we look for all of them. I think that I would argue that depression and anxiety symptoms appear with about equal frequency in our pain population. We screen for those comorbidities. And obviously, treatment of depression and anxiety is squarely in the province of a CBT practitioner.
Right.
But we also try to make sense of each of those things to the patients. We try to conceptualize why they might feel depressed. and actually, one of the things that we talk about quite a lot, particularly to the physicians, is that often a chronic pain presentation is really masking a depression. And if they're addressing pain with analgesics, particularly opiates that serve as central nervous system depressants, they're headed down the wrong path, because we know that narcotics aren't really a very good treatment for depression.
Absolutely.
So we look to see, to differentiate between pain and depression and address each of them in the context of the recognition that this is a normal accompaniment to pain. With anxiety, our emphasis mostly is on, again, after assessment, it is on exposure strategies, helping with desensitization, often hand in hand with the physical therapist. As Elizabeth alluded to, sleep hygiene strategies are important, and again, the patients who conceptualize their sleep disturbance as being pain-related may not be accurate. That's their belief, but the sleep disturbance may really be a manifestation of depression. And these days, the first-line treatment for insomnia is what's called CBTI, cognitive behavior therapy for insomnia.
Would you expand a little bit more on that?
Well, Elizabeth really, I think,
just
addressed
going
it.
through.
It is essentially the idea is that you do have to pay attention to the context, to the environment of sleep. You have to create essentially a rhythm to sleep where you're. It's particularly important to be getting up at the same time every day, no matter what, to avoid napping in the afternoon, to avoid stimulants after midday, and so forth. So basic behavioral strategies for making sleep that kind of pattern of sleep that we want the body to fall into naturally. And most patients don't understand that that can take 30 days or so to establish.
Before you, yeah.
And so part of this is counseling patients with the process and kind of hanging with it. And we certainly spend an awful lot of time on substance misuse, just because patients so often who feel as though they're not getting adequate pain relief from whatever strategies they're trying accompany the prescribed approaches with alcohol or other substances that really cause more problems than they solve. So we assess for that using a variety of strategies that we conceptualize as having convergent validation. No single strategy is ideal for assessing substance misuse, but if you come at it from the perspective of some questionnaires that you've embedded in some of the data you collect at the beginning of the visit, to confirmatory pharmacy reviews. Yeah. Most states, I think, now have pharmacy.
The pharmacy, yeah.
The database.
The database for drug, yeah.
We often will do conversations with collaborative sources, so we'll talk to family members and so forth about substance use. So each of these are common accompaniments to chronic pain that we try to address and then communicate back to the team as we find that each or several may be involved.
Do you recognize, Elizabeth, a lot of substance use while you are managing patients?
If there's a spectrum of substance use, then we probably only recognize the most extremes of those.
Okay.
But there are occasions when patients have a heavy reliance on their medication, and maybe that speaks a lot to their coping strategy as well, that it's a passive coping strategy. But sometimes you hear statements like, my doctor kind of wants me to decrease the amount I'm taking of XYZ, right. And I can't do that. I can't live without those medications. So we pick up on those types of things.
Right.
And then, we have had people fall asleep in therapy because they've taken too much medication. Yeah. And, that thing happens, but that's extremely rare. So to that degree, we pick up on that.
I have a question for you, Jeff. Can you speak to the literature, what the literature tells us about the relationship between a chronic pain syndrome and the diagnosis of depression or anxiety? We hear often that that person developed a chronic pain syndrome because they're depressed or because they're anxious. Yeah. Do we know anything about that from an evidence base?
Yes, absolutely. You're right that for some time there's been this controversy about sort of which comes first, the pain or the depression, for example. But research has shown very clearly that pain is the pain always comes first, not always, but the vast majority of circumstances, the pain is the issue that initiates a depressive response, an anxious response, so that the question of the chronology is pretty clear. Very rarely does depression specifically create a pain syndrome. It really almost always is the other way around.
Yeah, that was my understanding as well. Thank you for clarifying.
In this segment now, what we've discussed is how to identify and assess comorbidities that accompany chronic pain syndromes. And as we've seen in other discussions, the comorbidities that are common, anxiety, depression, substance misuse, sleep disturbance, are able to be assessed across all of the specialties. Obviously, some of these, depression and anxiety and so forth, fall mainly in the province of psychologists for assessment and treatment. But the manifestations of those comorbidities, particularly in the ways that the patients experience them, are particularly important for the physician to pick up on, for the physical therapist to be sensitive to, and to be included then in the team discussion so that all are aware of the roles of these comorbid kinds of problems as they coexist with chronic pain.